Welcome to Continuing Mobile Education for Emergency Medical Services Providers. This is Block 10, Cardiology in the Older Adult, Episode 3, Congestive Heart Failure. After viewing this episode, participants will review the pathophysiology of congestive heart failure. Participants will review the signs and symptoms of congestive heart failure. Finally, participants will review the pre-hospital management of congestive heart failure.
CHF is a chronic disease that increases in incidence through age. By the age of 75, approximately 10% of the population is afflicted with congestive heart failure.
In my experience, the geriatric population in congestive heart failure, it can occur 20 to 30% of the time. It's not every single case that we see it, but we do see a good portion of the population that do have problems with this, whether it's associated with cardiac versus some other process. At that point, it's hard to tell, but about 30%.
Congestive heart failure is a failure of the heart to work properly as a pump. This may occur either on the left side of the heart or on the right side of the heart. Essentially, it can occur either because of systolic or diastolic dysfunction. Systolic function being the heart's inability to properly contract and push blood forward. Diastolic dysfunction being the heart's inability to fully relax and allow proper filling of the blood so that an adequate amount of blood can be pumped forward and systole. The causes of CHF in the geriatric patient can be rather broad. It may be multifactorial, but we should keep in mind that the number one concern should be any potential cardiac ischemia. In addition to this, other causes may be medication compliance, dietary indiscretion, or any other factors that may increase stress on the heart. This may be anemia from a GI bleed, infection, dysrhythmia that causes poor perfusion and function of the heart. Age-related factors that play a role in the development of congestive heart failure include ischemia as well as scarring of the arteries. This may occur because of long-term disease such as hypertension or diabetes. In addition, as we all age, there is a decreased flexibility of the heart tissue. This may cause diastolic dysfunction as the heart is unable to properly relax and fill with blood during diastole.
Congestive heart failure is a chronic disease arising from factors such as age, diet, past medical history, and genetics. Congestive heart failure is a failure of the heart to function properly as a pump. Causes for exacerbation include medication compliance issues, diet indiscretion, anemia, and infection.
The classic signs of CHF are going to be shortness of breath, increased blood pressure, and then you might also have rales in the lungs.
The classic signs of CHF exacerbation are shortness of breath. This may be associated with exertion and may be situated with positioning. Particularly if the patient lies supine, he may report increased difficulty breathing. The patient may also complain of chest pain as well as diaphoresis. And the symptoms of right-sided heart failure consist with a dysfunction of blood being pumped from the venous system into the pulmonary system. This is represented by a backflow of blood. We should look at signs of failure by assessing for jugular venous distension. We can also check what is called the hepatojugular reflex by pressing on the right upper quadrant of the patient. You may note increased jugular venous distension, and as you let go, if the increased distension is persistent, this may be an early sign of right-sided failure. In addition to this, any peripheral edema may be consistent with right-sided heart failure. Left-sided heart failure consists of an inability to pump blood forward through the left side of the heart into the arterial system for the rest of the body. For this reason, blood is pooled into the pulmonary beds. Patients will typically complain of shortness of breath, and these patients should have auscultation of their lung fields, as these patients may present with either crackles or wheezes, indicative of fluid being built or fluid building up in the interstitial spaces of the lung. Both left and right-sided heart failure can occur independently or together. If there are signs of pleural effusion, typically this is because of dysfunction in both the left and right side of the heart. This may be noted by dullness to percussion or decreased breath sounds at the bases of the lung fields.
Pre-hospital assessment of CHF is going to include a good basic assessment and a good ALS assessment, an ECG, 12 lead. You want to do a good HPI, and then lung sounds. You want to also make sure that you add in CO2 or capnography. Is going to give you a good indication of whether it's CHF that is a result of or actually shortness of breath as a result of CHF versus emphysema or asthma, where you will see some differences in the waveform at that point.
Distinguishing between CHF, COPD, and pneumonia can be a diagnostic dilemma for providers. Typically, the number one reason for this is that as providers, we may be tempted to focus on one particular complaint. Patients with these underlying diseases may have a number of complaints that present very similarly. This may include cough, which all patients that have any sort of pulmonary pathology may be prone to. Patients with congestive heart failure also may have symptoms that are similar to pneumonia. They may complain of fever or may appear with diaphoresis. In addition to COPD, patients with cardiac failure may present with what we call cardiac asthma, and auscultation of the lung fields may sound very similar to what a patient with COPD may present with.
General symptoms of CHF include shortness of breath, fluid retention and swelling of the legs, dyspnea on exertion, paroxysmal nocturnal dyspnea, or PND. Signs of right-sided failure include jugular venous distension, hepatojugular reflex, or peripheral edema. Signs of left-sided failure include abnormal lung sounds such as crackles or wheezes and fluid in the lungs.
A typical, or actually a bad CHF call is very difficult to manage for a single provider. In that just sometimes they just rapidly progress and you just feel like you're kind of behind the eight ball all the time. The best way to manage that is just to maintain being calm and just make sure that you start from the beginning and just keep working right through. Obviously, when somebody is in acute CHF and they're having a very difficult time breathing, their stress level is really high. If you can maintain a very calm demeanor, it helps the patient to some extent, and then also helps you to stay calm and focused on what you need to do to get through the call. Treating CHF in the field for a BLS provider is going to be providing high flow oxygen and position of comfort as best as possible. Very important for BLS to make sure that they give a early request for ALS if ALS has not already been dispatched to the call. Good set of vital signs, and then if there is some time between when you're going to meet up with your ALS, if they're going to make it to the scene or not, is rapid transport and rapid movement towards your advanced life support. Advanced life support treatment of CHF is going to include, first and foremost, probably CPAP if it's an acute presentation. I'm also going to give nitroglycerin to help to reduce the blood pressure, and which will reduce the preload of the heart.
The pre-hospital management of CHF includes a complete physical exam, positioning of the patient, supplemental oxygen, nitroglycerin for ALS providers, and CPAP, also provided by ALS. After viewing this episode, participants will review the pathophysiology of congestive heart failure. Participants will review the signs and symptoms of congestive heart failure. Finally, participants will review the pre-hospital management of congestive heart failure.